any male child around the age of suppose 10 to 15 years of age, juvenile age group, coming to you with history of unprovoked epistaxis. Okay. Suppose in the morning in the bed, the patient is getting kind of a pool of blood from his nose. You will suspect about this tumor. Okay. This tumor is known for its complexity. Okay. One of the very difficult tumors of our body. Why? Because of its anatomical location. Okay. So, as you know, juvenile nasopharyngeal angiofibroma. So, juvenile age group is most common, more common in males, and its an typical location is around the nasopharynx. Okay. Traditionally is known as nasopharyngeal angiofibroma, but the actual location is in the what? Around the sphenopalatine foramen in the pterygopalatine fossa area. Okay. And angiofibroma. That means angio means blood vessels. Fibroma means it has some fibrous components as well. Okay. Definitely it's an oma, that means it's a benign tumor, right? Not all omas are benign, but it's a benign tumor. But its nature is very complex, okay? It can infiltrate. Mostly because of its pushing effect, it goes around the area, but it can infiltrate as well, okay? So whenever you touch this tumor, there will be a hell lot of bleeding, right? It will work in a pool of blood. So we need to address that situation. That is the challenge. Historically, when the angiofibroma operations are used to be done, either it's open or endoscopic approach, there used to be a lot of bleeding, okay? Hemoglobin 13 to hemoglobin 3. I personally have observed this phenomena. Surgeons can operate in this tumor. Okay, not anybody can operate in this tumor. Okay, so let's see. This is the look of the tumor, right? So patients are usually come with nasal obstruction and bleeding, unprovoked or spontaneous bleeding from the nose. If the patient tumor is extremely large, then it can have some other complications, right? From the pterygopalatine fossa, the tumor can go to the brain, the tumor can go to the eyes, the tumor can go to the cheek. So if there is eye involvement, then there will be eye related complication symptoms. If the tumor is in the cheek, in your cheek, then there will be asymmetry of your face. If the tumor is in your brain, then you will have other things, okay? And you know there are lots of foramens around your skull base. In this pterygopalatine fossa area, lots of foramens, like you can have foramen rotundum, you can have foramen spinosum, you can have foramen lacerum, foramen ovale, Vidian canal, other things, okay. So, suppose in the V2, that is the trigeminal nerve second division or the maxillary division, okay. If the tumor is infiltrating that area, you will have symptoms of the V2 related things, right? Numbness and all around your cheek, maxillary area. If the tumor is involving your optic nerve, then you will have blindness. If the tumor is involving your superior orbital fissure area, then can anybody tell me what are the structures going through the superior orbital fissure? Okay. Major structures. What are those structures? Any nerve supplying the orbit? Involved in eye movements. Oculomotor nerve, Trochlear nerve, bhalo kore bolo sequentially. Lacrimal nerve is a branch. Okay. I am talking about the main nerves. 6 abducent nerve and V1. তাই তো? Optic nerve কোথা দিয়ে যায়? Ophthalmic vein. Okay. Anything? So like that, এটা যদি তোমরা interested হও, I can take another class anyway. So if it is involved that area, then he will have symptoms of that, তাই তো? So ophthalmoplegia and proptosis can as well. Okay. So it's a benign, it's well circumscribed, okay, but it can infiltrate as well. Infiltrative means you cannot have a well-defined capsule. It can infiltrate the bones and the nerves and the nearby structures. And it's locally invasive, right? So these are the qualities of a malignant tumor. But this tumor can also have this kind of quality, little bit of. And it can spread submucosally. Okay. This is also a challenging thing. If a tumor is not well defined, then you will have a difficulty during the surgeries. Right. So adolescent males, right? So males are poor candidates in earth. So severe morbidity but low mortality. Why morbidity? The tumor itself cannot kill you. Okay. But it can kill when there is lots of epistaxis. Gradually it will kill you. But morbidity is extremely high. Okay. So every other day a child is having the fear that I will have some epistaxis. The patient is having other cranial nerve problems, nasal obstruction. So these patients are having severe morbidities. First described by Hippocrates. Everything has been described by Hippocrates on the earth. Okay. So there are some documents that this tumor has been described by Hippocrates. Actually, he described it as a nasal polyp that bleeds a lot. Okay. So this angiofibroma term has been coined by Professor Friedberg. Another thing, 0.5% of all the head and neck neoplasms, but the incidence is gradually decreasing. Okay. And there is obviously something related to the androgen receptors. Otherwise, it cannot happen in males. Right. There are 2 or 3 cases that this tumor happened in females as well, but mostly in male. And it has some indolent course. Okay. What do you mean by indolent course? Remember this name, Radowski. He has an extensive research on angiofibroma. It has some indolent course. That means the patients usually come after some symptoms. Okay. And after some symptoms, some brief period of time, we get a diagnosis. So this tumor must have a big vessel supplying, right? Otherwise it cannot bleed like this. The vessel is internal maxillary artery. You have to remember this. Okay. Internal maxillary artery, second part or the third part is the main blood supply. So if we want to operate on this tumor, we have to address this artery first. Right? If we clip that artery first, then the tumor will bleed less during the surgery. Apart from that, if it is a big tumor, it can also have some supply from the internal carotid artery, from anterior ethmoid artery or posterior ethmoid artery, right? And occasional, it can have contralateral supply. There are occasions that bilateral angiofibroma happens. There is another tumor in the body that bleeds like this. Can you name? এরকম ভাবে ব্লিড করে head and neck. Head and neck is about vessels. This carotid body tumor, right? That is also a kind of paraganglioma. This is also paraganglioma. Okay, but the pathophysiology is kind of different. Very surprising. Glomus also bleeds. That is also paraganglioma. Okay. So here, if the tumor is large, you can have a bilateral. If you have a bilateral JNA, then you can have a contralateral supply as well. Taito. So where from it does it arise? We have a case series in our PG time that we found that most of the tumors arising from the videal canal area. Okay, but the literature is saying mostly from the sphenopalatine foramen area. Okay, there are other theories. It can also arise from the basis sphenoid area as well. Okay. So it's a chondrocartilage of the skull bones. That is the actual site of origin. Anywhere if there is a chondrocartilage, you can have this thing. Okay. So superior margin of the sphenopalatine have lots of this thing, and where there is trifurcation of bones, okay, you can have this thing. Okay. This is the sphenopalatine foramen, right? From where the sphenopalatine artery gives its branches, started giving its branches. And pituitary androgen estrogen axis I have already told you about, and estrogen, androgen receptors are also having a great importance. So it's a basically vascular hematoma. Okay. I'm not good at pathology. Anyway, you just understand this thing. These are the receptors. Okay, insulin-like growth factor 2, transforming growth factor beta 1, vascular endothelial growth factor receptor 2. If you want to research on this, you can have a what? I don't know. I need to get the tumor out from your body. That's it. That's my job. Okay, the myofibroblast origin. It has a pseudocapsule, multiple vascular channels, and muscular layer is absent. Okay, not always true. Sometimes it can happen. So how does it present? Mostly epistaxis. Second is nasal mass, and the epistaxis is recurrent. Epistaxis is unprovoked. Okay, এমন নয় যে পেশেন্ট নাক খোঁচাচ্ছে তারপর ব্লিডিং হচ্ছে। হ্যাঁ, সকালবেলায় ঘুম থেকে উঠে দেখছে লটস অফ ব্লাড, তাই না? Then you have to suspect it. So it's a smooth lobulated tumor. You have a visual impression as already. It's compressible and red tissue. If you suspect this tumor, then you have to investigate. What is the investigation of choice? What do you think? It's a CT, and it should be contrast enhanced. Why contrast enhanced? Because it is a vascular tumor. Okay, and if CT is enough, you should always have an MRI as well, MR angio. Okay, do you get a biopsy? Why? If you get a biopsy, then you are in trouble. Patient is trouble, okay, and you are also in trouble. You cannot control the bleeding. Okay. Okay. What are the atypical presentation? Why there is middle ear effusion? Because the tumor is in nasopharynx. So eustachian tube orifice will be blocked. So patients may have middle ear effusion. Why dacrocystitis? Nasolectremal duct opening will be blocked. So there will be, the drainage will be hampered and the patient will have dacrocystitis. Rhinolalia, clausa and apata. Both can happen. Okay. So rhinolalia will be there. Sorry. Palate deformity will be there because it will push, and the growing bones, it will take the shape of the pressure. Right? Hyposmia, anosmia. I think I need not to explain this thing because there is obstruction. Right? As well as it can also, because of the olfactory fibers, can also involve. It can reach at that area. But mostly because of the obstruction. Okay. Facial swelling, I already told. Proptosis, I already told. Cranial neuropathy, I have already told. Okay. So how will you extend? So the tumor will find a natural defect in your skull base, right? So what are the defects? What are the communications of the pterygopalatine fossa? Very complex area. Okay. So, देखो, arrows, follow the arrows. It can go to the it starts at the pterygomaxillary fossa or the pterygopalatine fossa or the sphenopalatine fossa, whatever. Huh? Behind the maxilla in front of the pterygoid plates. Right? That area. It can go laterally into the infratemporal fossa. Eglo jana ache, these spaces? Or do I need to take another class on it? Dur first year anatomy. Idea high. Class hoyeche egloর উপর? Okay. Anyway, I will take a class on the deep neck spaces of the head and neck. Okay. That is the real challenge. The superior orbital fissure. It can go to the cavernous sinus. Cavernous sinus anatomy জানা আছে? Pituitary দুদিকে থাকে, তাই তো? Okay. হ্যাঁ, ফ্লোর আছে, ওয়াল আছে, ল্যাটারাল ওয়াল আছে। অরবিট জানা আছে? অরবিট অ্যানাটমি জানা আছে তো? Okay, so it can go to the orbit. Okay. And intracranial. Anterior cranial fossa, middle cranial fossa, it can go to the pituitary. And suprasellar extension also can be possible. Huh? Yes. If it is too large. So, remember this flowchart? So, সব জায়গায় যেতে পারে, তাই তো? সব জায়গায় টিউমার তো যেতে পারে, আমি কি করে যাব? That is the challenge. Okay. The tumor is known for recurrence. Why? Not because of its pathology, because of the incompetent surgeon. Okay. He cannot go endoscopically into the orbit. He cannot go endoscopically into the pituitary region. So what will happen? The tumor will be there. So that is a residual tumor. So it will recur. And it's very common. Okay. So the research saying up to 46% is the pending surgical technique. Okay. We are afraid of one thing in that area. The one thing is our carotid artery. If it's cut or injured, no, dead, now hote pare, but he will be in trouble. Okay. Anesthesia will have a heart attack and he will be in trouble. Okay. Okay. So, we have to now address this thing. Okay. What are the differential diagnosis? Etai porikhay jigesh korbe, eto kotha jigesh korbe na. Okay. So, vascular fibrous nasal polyp or angiomatous polyp. তাই তো এরকম লুক হতে পারে কাছাকাছি। Pyogenic granuloma, hemangiopericytoma, antrochoanal polyp, and craniopharyngioma, chordoma, olfactory neuroblastoma, nasopharyngeal carcinoma, and rhabdomyoid sarcoma. সবগুলোই বড় বড় জিনিস, তাই না? Okay. So staging, Radowski staging, that we mostly follow. Many people from India also, they have attempted some staging system, but it mostly depends on the extension. Where does it go? If it is intracranial, then it's the highest staging. If it is not invading the dura mater, then it's lower staging. Right? So just remember the name. Okay, that is the most important thing. How do you diagnose? With contrast enhanced CT scan. Right? So what typical thing you will get in CT scan? Look at this area. This is the tumor. Okay. I will give you a better picture. Okay. Just look at this area. This is the tumor. Right? Agar din CT scan ami at a class nilam. So I think you are able to recognize the different anatomies, radio anatomies. This is your septum. This is the nasopharynx choana area. Right? কি থিওরি ক্লাসে তো হবে না ওটা, ঠিক আছে তুই চলে আসবি পড়ি দেবো আলাদা করে। Anyway, this is the this is the maxilla, right? Okay. Behind the maxilla and in front of this pterygoid process, this is the pterygomaxillary area, fissure. or pterygopalatine fossa, just lateral to it. Okay. So just look at the posterior wall of the maxilla here and posterior wall of the maxilla here. Do you find any difference? It's pushed in front, right? So pushed forward. So this sign is known as Hohmann-Miller sign. Okay, you can get it also in X-ray. But we have found that this sign is present only in 60% of cases. There are other signs, right? The widening of the pterygoid processes, erosion of the pterygoid fossa, etc., etc. Okay. And this phenolpalatine foramen is widened. It happens in most of the cases, around 90% of the cases. Okay. So this is the Hohmann-Miller sign. This comes as an MCQ, and this is the tumor. Look at the extent of the tumor. This is the infratemporal fossa, where this is the masticator space actually. Okay. You will have all the important muscles of mastications and arteries and other things there. So the tumor has been extended into the infratemporal fossa, right? So MRI is also important, right? Because for soft tissue evaluation. And if there is any extension into the brain, dura involved ache ki na, cranial nerve involved ache ki na, you cannot get this idea on CT scan. Okay, you have to have an MRI. So it has a diffuse contrast enhancement. What happened? Okay, diffuse contrast enhancement on T1. Right? This is the typical. And angiography. এখনকার যুগে MRI angio হয় non-invasive, so no need of that. But initially we used to do it. দুটো কারণে angiography এখন করতে হতে পারে। এক হচ্ছে if the tumor is too vascular, we will temporarily embolize the tumor. ঠিক আছে? With angiography we will embolize the tumor before the surgery. Within 24 hours you have to operate. So there will be less bleeding. But we don't prefer this thing, especially in India. Why? Because with embolization the tumor can shrink. So তুমি ভাববে অপারেশনের সময় this is not the tumor and you will leave some residues there, right? এতটাই shrink করতে পারে। এতটা shrink না করলে করব কেন? Bleeding যদি নাই কমাতে পারে, why will you do this invasive procedure on a patient, right? So sometimes it can get, you will get confused that this is not a tumor, just a fibrous tissue and leave behind, and this will recur. Okay? বাইরের দেশে করা হয়, আমাদের দেশেও করা হয় না তা নয়, but we feel that we are better surgeons than them, so we don't embolize. Okay? Anyway, and another thing is, if you are suspecting that this carotid needs to get manipulated or it needs to get ligated at one point of time, so internal carotid artery যদি ligate করে দি কি হবে? Blood supply বন্ধ হয়ে যাবে, so patient will have stroke. Okay, so তাহলে এটাকে ওভারকাম করার সিচুয়েশন কি? হ্যাঁ, টেম্পোরেট করে কি, তো মেন সাপ্লাই বন্ধ করে দিয়েছিস, so you have to have some collaterals, তাই তো আলটিমেটলি অন্যদিকে ইন্টারনাল ক্যারোটিড গিয়ে সাপ্লাই দিয়ে কোলাটারাল তৈরি করবে, so patient will have less morbidity at least, তাই তো? So because of these things sometimes we start doing embolization temporarily, okay, so that the patient is starting developing collaterals, right? And we will have a judgment beforehand that it can shrink the large tumor. Gel foam and polyphenol alcohol foam is used for embolization. And what is the complication? If the emboli gets dislodged in your midcerebral artery or anywhere else, you will have a stroke. And if it blocks your ophthalmic artery, then you will have blindness. Okay. Now coming into the treatment. Treatment is surgery, nothing else. Okay. Other treatment are being tried. Radiation. This is one condition when there is no cancer but we give radiation. Okay. Another tumor is acoustic neuroma. Okay. Suppose during operation you suspect that a small residue is there, you cannot remove it, it encircling all the carotid arteries and all, you are afraid of any complications, then you can do a radiotherapy as well, okay. We can give some chemotherapy, we can give hormone therapy because it's an androgen receptor related condition, okay. So anti-androgens we can give. So surgery is the treatment, right? So how do you do the surgery? Now the question is that. What is the basics? First thing, you cannot do a biopsy of this tumor. You cannot just debulk the tumor, cut it out, then go inside, cut it out and go inside. You cannot do that. So you have to get around the tumor, right? So to get around the tumor, you have to create some corridors. তাই তো? তুই হঠাৎ করে তো ঢুকতে পারবি না ওই জায়গায়, তাই তো? You have to drill all these things out. You have to get around the tumor. You have to ligate the vessels and ultimately you have to take it out. Okay. So the main challenge is how to reach at that area. Okay. So nowadays the treatment of choice is endoscopic transnasal approach. Though the treatment of choice is endoscopic endonasal approach, but this tumor you have to be well conversant with all the approaches. Okay, there are open approaches as well. যখন এন্ডোস্কোপ ছিল না তখন লোকে কি করতো, তাই না? ওপেন করেই করতো। এখনো অনেক সময় আমাদের ওপেন করতে হয়। So you have to know about all these tumor approaches. So the area of interest is pterygopalatine fossa and nasopharynx, তাই তো? ছোট টিউমার হলে we can go transpalatal. We'll give a incision in your hard palate soft palate junction, okay, and we will expose the tumor, we will resect the bone as required and we can do a finger dissection, তাই তো? আঙুল দিয়ে টিউমারটাকে বাদ দিয়ে দেওয়া, তারপর ব্লিডিং হচ্ছে প্যাক প্যাক করে we will wait, আবার ব্লিডিং হচ্ছে আবার প্যাক প্যাক করে ওয়েট, আবার ব্লিডিং হচ্ছে প্যাক রেখে দেবো, ঠিক আছে? This is the surgery, that's used to be the surgery, okay. But you cannot do this surgery in a large tumor, can we? No, we cannot reach other areas, okay. So there are other lateral rhinotomy approach, okay. So we will give an incision, lateral rhinotomy incision. We can extend the incision as well, okay. শুধু যদি এইটুকুটা incision দিই, just এইটুকু, অরবিটের কিছু দিলাম না, ঠিক আছে, then it is a lateral rhinotomy. যদি এটা অরবিটের আশেপাশে অবধি এক্সটেন্ডেড হয় then it is a lynch incision. যদি অরবিটের নিচে পুরো অরবিটটা এক্সপোজ করতে হয় then it is Weber Ferguson incision, okay. So as required we will do it. We will open up the maxilla, we will drill the posterior wall of the maxilla, we will go straight into the pterygopalatine fossa, ঠিক আছে? We will clip the internal maxillary artery and we will take the tumor out, okay. Again the limitation is we cannot see the interiors, তাই তো? আমরা ভেতর অবধি তো ভালো করে দেখতে পাচ্ছি না, এটা অন্ধকারের মধ্যে কাজ। Again we will close it, we will give a pack, we will come out, okay. This is another mid-facial degloving approach, okay. We will deglove the mid-face, basically মুখটাকে mid-face-টাকে পুরো ওপেন করে দেওয়া, okay. If the tumor is having a bilateral extension or a large tumor, we can do this approach. This is the mid-facial degloving approach, okay. And if the infratemporal fossa is involved, then we can go for the infratemporal fossa approaches, A, B, C, like this, huh? Anyway, so nowadays we do endoscopic approach, okay. We'll cut the middle turbinate. We will do the endo-Denker procedure, that means endoscopically medial maxillectomy. We will go to the tumor, we will clip the maxillary artery, we will drill the basis sphenoid, we will go to the orbit, we will go to the brain as required, we will go to the Vidian canal area, we will do whatever is needed and we will come out. So what are the complications? Severe bleeding, we can cut the V2, so there will be cheek paresthesia, there will be extensive synechiae, there can be, okay, because lots of soft tissues are being handled. You can have damage of all the cranial nerves, 3, 4, 5, 6, whatever, okay. So you can have an idea, you can injure all the things, right, around this area. Pterygopalatine ganglion, from pterygopalatine ganglion to your optic nerve, your cranial nerve 3, cranial nerve 4, cranial nerve 6, median nerve, sphenopalatine artery, okay, your V2, you can injure your palate, you can injure your brain, you can have CSF leak, you can have massive bleeding, all these things is possible. And most difficult complication is residual. So how will you manage the residual? We will get a CT scan next day of surgery and we will see if there is any residual. If there is any residual, we will get back the patient into the OR again, okay, and we will do the needful. If it is not resectable, then we will go for other things like radiotherapy and all. Okay. So these are not required for your level. This planning and all. Radiation is a treatment. The dose range is 30 to 46. And it has a complications. Radiation has a complication, right? Radiation a complications, right? Whatever it is, teletherapy, whatever, okay, it has a complications. So it can arrest the growth of the craniofacial region, it can have radiation induced cataract, radiation necrosis, brain necrosis, osteonecrosis, osteomyelitis, lots of things, okay, if you are not outline your area well. So nowadays we have gamma knife, cyber knife, have you heard? This is a type of radiation only, okay. So gamma knife, cyber knife, it's a precise radiation of that area, but still the area is not alone. It has lot of things there. So you will damage those areas. Chemotherapy as well, it's rarely used, okay. Few medical oncologists have tried, but it's rarely used. Hormonal therapy. If you have a estrogen therapy, then you can have some androgen receptors, you can bring those receptors sensitivity down and tumor will grow slowly, okay. The physical and psychological side effects are there. Feminization of a male person, okay, this is a psychological embarrassment for the patient. What are the instruments we used, right? To control those bleedings, we can use coblation. Coblation is extensively used for this tumor, right? We can use cryotherapy, we can use bipolar cautery, monopolar cautery, gamma knife. Gamma knife is it a knife? It's a radiation, right? Okay. Harmonic scalpel, pre-operative, post-operative brachytherapy. What is brachytherapy? Radiation probe dewa, taito? Okay. KTP laser, sclerotherapy, all these things. So, shesh hoye gelo. What is this? So, conclude it. What is nasopharyngeal angiofibroma? It's a benign vascular tumor, vascular hematoma or paraganglioma, taito? Mostly happening in juvenile age group males, taito? Around, peak of the age is around 12 to 16 years of age, right? It has some, why we are reading it separately? Because it comes with a lots of bleeding before operation, during operation, right? Surgery is the treatment. It can have many complications. If the tumor is big, we have a staging there known as Radowski staging. The treatment of choice is endoscopic endonasal approach. There are other open approaches like transpalatine approaches, lateral rhinotomy approaches, midfacial degloving, and tumor is known for recurrence. It's not recurrence, basically residual. We have other treatments like radiation and all, okay, for small residues, okay. The treatment is basically surgery. And if the tumor is complicated, it can go to It can go to many important areas, like through, what are the other areas it can go from the pterygoparietal fossa? To the orbit, to the brain, orbit through superior orbital fissure, to the infratemporal fossa via pterygomaxillary fissure. It can go to the other things. It can go to the brain, cavernous sinus, it can go, right? It can go to the pituitary and all. Okay?